So this is the basic unit of your kidney, which is your nephron. To review with the anatomical parts of your nephron, this is your glomerulus, this is your proximal convoluted tubule, this is your descending loop of Henle, the thin ascending loop of Henle, the thick ascending loop of Henle, the early distal convoluted tubule, and the late distal convoluted tubule, and then your collecting duct. So your antidiuretic hormone will have an effect to the late distal convoluted tubule and in your collecting duct, in your principal cells. So as a bigger picture, so this is your peritubular capillary, this is your basolateral side, note, again, this is your blood vessel or your peritubular capillary. This is the basolateral side or your what we term as your interstitium. This is your luminal side. This is where your water is being excreted as urine. So this water will now be excreted as urine. This is your V2 receptor. This is your aquaporine. This is your storage vesicle that contains your aquaporine. And this is your protein kinase A. Again, this is your V2 receptor, aquaporins. This is your aquaporins that is still not attached to your cell membrane. This is your protein kinase A. So doc, why do we have to release your antidiuretic hormone? Your antidiuretic hormone is being released in cases of dehydration, when we do not have enough water in our body or when there is a decreased blood pressure. So different scenarios that can lead to a decrease in water inside our body, the normal physiology or the normal physiologic response to this scenario will be increasing the release of your antidiuretic hormone. From the name itself, antidiuretic hormone. You want to prevent the release of this water by means of increasing their conservation. So how do you do that? Your antidiuretic hormone will now attach to your V2 receptor. Remember, your antidiuretic hormone will have two receptors, V1 in your blood vessel and V2 in your kidney. So when your antidiuretic hormone is attached to your V2 receptor, what happens is that your CAMP will be increased. There will be increased production of your CAMP. Your CAMP will now go to your protein kinase A to activate it via phosphorylation. Your pKa now, once pKa is activated, it will activate your storage vesicle to insert their aquaporine 2 towards the luminal side of your cell. This luminal side, when this aquaporine will be inserted, it will now help water pass through the cells and be conserved inside our body. So ito yung mga aquaporins. Aquaporins once activated, and then aquaporins here because this serve as your water channel. And now your water can able to pass through the cell and be able to go to your interstitium and can be used by the body. So in short, the main purpose of your antidiuretic hormone is to conserve water basically through this aquaporine 2 inserted in your cell membrane in the luminal side of your principal cells. So your ADH can be stimulated when there is an increased osmotic pressure or a decrease in blood pressure. These changes in your osmotic pressure and your blood pressure can be detected by your osmoreceptors or baroreceptors, which will stimulate your hypothalamic neuron. Remember, your hypothalamic neuron will be able to secrete antidiuretic hormone. What hypothalamic neuron it is? It is this. This is your supraoptic neurons. Remember your supraoptic neurons? Tama ba? Supraoptics? Yeah, supraoptic. Walang O. So, ADH ang partner. So, supraoptic will release your antidiuretic hormone. And this antidiuretic hormone will have effects to your blood vessel via V1 receptor to vasoconstrict or via V2 receptor in the kidneys to increase reabsorption of water. So when you are able to constrict your blood vessel or increase reabsorption of water, now it will correct the increased osmotic pressure or decrease into blood pressure into increased blood volume, increased blood pressure. So how do we regulate your antidiuretic hormone secretion? In regulating your antidiuretic hormone, these are the different factors that will lead to increase your anti-ADH secretion. When this is high serum osmolarity, this is your volume contraction, this is pain, nausea, hypoglycemia, nicotine, and etc. Factors that decrease your antidiuretic hormone, decrease serum osmolarity, ethanol, alpha agonist, and your ANP. Remember that the most potent regulator that will stimulate or inhibit your vasopressin is your serum osmolarity, whether increased or low. Your serum osmolarity is the most potent stimulus for the release or stimulation or inhibition of your antidiuretic hormone. So, Doc, what is plasma osmolality? How do we differentiate your plasma osmolarity with your plasma osmolality, diba? There's a difference between your plasma osmolarity, R and the L. When we say plasma osmolarity, it is equals to the number of solute particles over osmolarity over per liter of solution, per liter. So the unit is per liter. Number of solute per liter of solution. How about your osmolality, Doc? Your osmolality, number of solute of particles over kilogram of solvent. Meaning osmolality, osmolality per kilogram of solvent. Osmolarity per liter of solution. So, Doc, what is the right? So, Doc, now, in terms of clinical aspect, what should we use? Is it plasma osmolality or plasma osmolarity? Now, we have to know the difference between the two. However, according to my readings, your osmolarity and your osmolality have in terms of in dilution, your osmolality and osmolarity doesn't have any significant difference. So, in a clinical aspect, we can interchangeably change the term osmolality or osmolarity. So it's fine as long as in a clinical aspect. So we can use osmolality or osmolarity. But in a biologic system, osmolality is more appropriate. So that's why we prefer the term osmolality rather than your osmolarity. So this is the formula for your serum osmolality. 2 times sodium plus your BUN over 2.8 plus glucose over 18. As what you can see here, majority of the value of your serum osmolality comes from your sodium. That is why your plasma sodium normal value is 135 to 145 millimoles per liter. The normal value for plasma osmolality will be 280 to 295 milliosmol per kilogram. Any changes in the value of your plasma osmolality, whether increase or decrease, will stimulate now the level of will stimulate or inhibit the secretion of your antidiuretic hormone. Let's take a look at this example. So how do we regulate our plasma osmolarity? But this is main of osmolality ha. Pag biologic system, we prefer your plasma osmolality term. So we prepare plasma osmolality. Sorry, this should be plasma osmolality. But some books still use plasma osmolarity. So accomplished by varying the amount of water excreted relative to the amount of solute excreted in response to water deprivation or response to water intake. So this is the normal scenario. Water deprivation or water intake. Hindi ako umiinom ng tubig, umiinom ako ng tubig. So what is now the immediate effect on the plasma osmolarity? When we say plasma osmolarity, kung sa ating terms lang para mas madali nating intindihin, plasma osmolarity is para siyang asin sa ating katawan. Not the literal asin, but the solute. This refers to the solute kasi nakita natin sa formula, it comprises of your sodium, BUN, and your glucose. So basically, your plasma is the asin sa ating katawan. So immediate effect on the plasma osmolarity, water deprivation. Walang tubig sa ating katawan. Mas maalat ba kung walang tubig? Yes. So, plasma osmolarity with water deprivation, the immediate effect will be increased. How about doc, water intake? Umiinom ako ng tubig. Kung may asin sa aking katawan tapos umiinom pa ako ng tubig, nagiging malabnaw ang asin. Magiging malabnaw ba ang asin? Tama. So in short, plasma osmolarity will be decreased. So doc, what will be the effect of your osmoreceptor in your anterior hypothalamus? Will stimulate or inhibit water deprivation? Wala, hindi ako umiinom ng tubig. So, kailangan ko ba ng tubig sa aking katawan? Of course, kailangan ko ng tubig kasi masyado nang maalat. Kailangan ko ng tubig. So, paano ako makaka-conserve ng tubig? It is through the release of your antidiuretic hormone. So, that's why your osmoreceptors in your anterior hypothalamus will be stimulated to secrete your antidiuretic hormone. In short, pag stimulated, increase ang production ng antidiuretic hormone kasi nga ayaw kong magpalabas ng tubig. Kailangan ko ng tubig. Kailangan kong mag-conserve ng tubig. So, paano ako makakonserve ng tubig? It is through the release of ADH, your antidiuretic hormone. Paano naman po, Doc? Wala akong... Paano naman po... Ay, dito na muna tayo, sorry. Effects on water permeability in your distal tubule and convoluted and your collecting duct. Of course, effects on water permeability, kasi nga mataas ang ADH, permeable ba ang nakaka-pass through ba ang ating water molecule sa ating collecting duct? Of course, kasi nga kailangan ng tubig. Effects on urine osmolarity. Anong mangyayari sa aking ihi po, Doc? Urine osmolarity. Nagiging malabnaw ba ang aking ihi? Or nagiging mas maalat ang aking ihi? Mas marami bang asin sa aking ihi? Ganito yan. Urine osmolarity. Diba? Kanina nakita natin, pag meron tayo antidiuretic hormone, pumapasok yung tubig. Pumapasok yung tubig. So ano nangyayari? Naiiwan yung asin sa ating ihi. So in short, we just conserve water and the solute are just left in the lumen. So what happens is that your urine osmolarity is increased. Your urine osmolarity is increased. Ano nangyayari sa aking urine volume po, Doc? Kasi nga, pino-conserve natin ng tubig, pinapasok sa ating katawan, lalong lumiliit. Kasi nga, maliit ang volume ng ihi, lalong nagiging maalat. So, anong final result sa ating plasma osmolarity? You will be decreased in your plasma osmolarity back to normal. So, in short, pinapalabnaw ang ating plasma so that it will go back to its normal. Paano naman po, Doc, ang water intake? Masyado akong umiinom ng tubig. Maraming tubig ang aking iniinom. Sorry guys. I have to drink water. sorry. Dahil lang. So, like me, paano po, Doc, umiinom ka ng tubig? Ano nangyayari po, Doc? So in short, water intake will result into ano nangyayari sa plasma osmolarity? Ano nangyayari sa asin sa ating dugo? Nagiging malabnaw. Kasi nga, nagiging malabnaw siya kasi nga maraming tubig. So, anong mangyayari? Kailangan mo ba bang i-stimulate ang anterior hypothalamus para mag-secrete, para mag-preserve ng water? Of course, hindi. I-inhibit natin siya. So, i-inhibit natin siya, liliit, hindi tayo magsisikret ng ADH. So, anong mangyayari sa water permeability sa ating collecting duct? Of course, bumababa. Kasi nga, hindi natin kailangan ng tubig. So, yung tubig, hindi makakapasok. Kasi nga, marami na tayo ng tubig. Hindi na tayo kailangan mag-conserve. Ano naman mangyayari sa urine osmolarity, Doc? Kasi nga, sobrang dami ng ating tubig and hindi naman natin kailangan i-preserve yung tubig. So, lumalabas ang tubig sa ating ihi. So, yung asin sa ating ihi is lalong nagiging malabnaw. That's why your urine osmolarity is low. Effect sa ating volume sa ihi. Of course, mas marami tayong iniinom na tubig. Hindi na tayo nagre-release ng ADH. Mas lalong maraming ihi ang lumalabas. So, ano pong resulta, Doc? Ano pong final result? Increase in your plasma osmolarity back to normal. I hope you understand that scenario. If you still confused with this one, please PM me or message me anytime. So, this is just a review of what we discussed a while ago. Ito na yun lahat-lahat, guys. I-review lang natin ha, para at least paulit-ulit na review, mas lalo nating naiintindihan. Water deprivation, hindi ka uminom ng tubig, nagiging maalat ang ating dugo sa ating katawan. So, isi-stimulate ang anterior hypothalamus para isikret ang ating antidiuretic hormone. Ang itong antidiuretic hormone will cause water permeability para dumami ang tubig na inaabsorb. Ang nangyayari, nagiging malabnaw ang ating ihi, pero lumiliit ang kanyang volume. Ay, hindi pala nagiging lamadlaw, nagiging mas maalat or mas increase ang osmolarity ng ating ihi and lumiliit ang urine volume. So as an effect, there will be decreased plasma osmolarity towards normal. How about water intake? Marami tayong tubig. So in short, nagiging malabnaw ang ating plasma, nagiging mababa ang plasma osmolarity. So hindi mo man kailangan ng tubig, so hindi natin kailangan stimulate ang osmoreceptor. In short, mababa ang ADH. Kung mababa ang ADH, hindi makakapasok ang tubig. Kung hindi nakakapasok ang tubig, hindi natin kailangan mag-preserve. So yung tubig is hindi nire-absorb. Hindi natin nire-absorb ang tubig sa ating ihi is lalong dumadami pero nagiging malabnaw. That's why it will increase your plasma osmolarity towards normal. Now let's proceed. We're almost done. Let's proceed with the pathophysiology of your antidiuretic hormone and arginine vasopressin. So these are the three most important pathophysiology that you need to understand by heart. When we say primary polydipsia, it is excess consumption of fluid. So inom ka lang ng inom ng tubig. There are two scenarios for two types of primary polydipsia. We have your psychogenic primary polydipsia. Ito yung mga patients with psychiatric disorder. I've seen a lot of my patients with schizophrenia or schizoaffective type of schizophrenia. They tend to increase their water intake, and the thing of why they have that increase of water intake, it's still unknown. Hindi pa namin alam. It's still on study. There are still studying on that part kung bakit ba palagi silang umiinom ng tubig. For your dipsogenic, it is a compulsory water drinking or habitual polydipsia. So in short, you have the control. It's not really the control, but you really wanted to increase your water intake, or it's already part of your habit to increase your water intake because you believe that drinking too much water will probably be healthy or beneficial on your part. So that's a type of a dipsogenic type of polydipsia. Again, primary polydipsia, ini-increase yung consumption of fluid. It's either be psychogenic, related to psychiatric disorder, or dipsogenic, when there is a compulsory or habitual polydipsia. Number 2, we have your diabetes insipidus. Your diabetes insipidus, there is a passage of large volumes of diluted urine. It could either be central or it could either be nephrogenic. Central, kulang ang pinuproduce mo na antidiuretic hormone. Deficient ang antidiuretic hormone. Nephrogenic, meaning failure of the kidney to respond your antidiuretic hormone. Meron kang antidiuretic hormone, kaya lang hindi nagre-respond ang iyong kidney. So in short, the problem here is your receptor. Number 3, we have your syndrome of inappropriate antidiuretic hormone or your SIADH. There is excessive levels of your antidiuretic hormone. In short, marami kang pinuproduce na antidiuretic hormone. So SIDH, diabetes insipidus, and primary polydipsia can easily be identified because of the different laboratory diagnostics that we are going to discuss now. But first, let's differentiate diabetes insipidus from your diabetes mellitus because their manifestation is the same. However, in terms of the specific gravity in your urine, they will have a difference. So in short, sabi ko, diabetes insipidus, passage large of volume of water. So people are keep on drinking water. This polydipsia, because marami kang tubig na iniinom, it will result into polyuria. So how will you differentiate diabetes insipidus from diabetes mellitus, doc? Through your specific gravity. Decreased specific gravity in your diabetes insipidus because of decreased production or function of your antidiuretic hormone. How about in your diabetes mellitus, doc? Increased specific gravity because decreased insulin or decreased function of insulin. There is increase in glucose. The increase in glucose will be the one responsible of increasing your specific gravity. So one way of differentiating your diabetes mellitus from diabetes insipidus is through your specific gravity. Specific gravity of your diabetes insipidus is true because of your specific gravity of your diabetes insipidus is decreased, while your specific gravity of your diabetes mellitus is increased. So, Doc, ano bang difference in terms of DM from diabetes insipidus? Your diabetes mellitus, guys, it's a problem in your insulin. There is deficiency or resistancy of your insulin. Remember, in your diabetes mellitus, I know that you will discuss this in the pancreas part. I know, so to give you an overview in terms of the diabetes mellitus and diabetes insipidus, this is how to differentiate the two. For diabetes mellitus, it could either, basta ang general, diabetes mellitus, the insulin is the problem. In diabetes insipidus, the problem is your antidiuretic hormone. In diabetes mellitus, there is deficient or resistant insulin. Diba? Your diabetes is divided into type 1 and type 2. Type 1 is your insulin resistant type. I know, insulin deficient or insulin, kulang ka sa insulin or insulin deficient. Type 2 is your insulin resistant. So in your type 1 diabetes mellitus, it's actually an autoimmune disorder wherein you are attacking your own cells. Since you are attacking your own cells, particularly your beta cells of your pancreas, it will lead to the destruction of your beta cells, leading to decreased level of your insulin. So sa type 1 na DM, decrease ang iyong insulin. How about sa type 2? Sa type 2 naman, guys, you have a normal level of insulin. However, your body does not respond to this insulin, meaning there is insulin resistance. So the problem in diabetes mellitus is insulin. There is insulin deficiency or insulin resistance. How about, Doc, for diabetes insipidus? Your diabetes insipidus, there is deficient ADH. This is what you call as the central type, or there is ADH resistance. This is your nephrogenic type. I hope that's clear. Now, Doc, how about causes of your SIADH? There are a lot of causes of your SIADH that leads to excessive levels of ADH. I have able to see a case of malignancy from a small cell lung carcinoma that manifests with syndrome inappropriate ADH. There are also drugs, primary brain injury, infection, hypothyroidism, kidneys, and many more. So generally, your SIDH is just an umbrella of the different disorders that could still happen, or your SIDH could just be a manifestation of an underlying disorder. So now, let's proceed with the... We have already last 2 slides na lang, guys. I'm already... Namuna ako ng tubig. I don't want to pause this para isahan na lang. So this is now the summary of your antidiuretic hormone pathophysiology. Now this will discuss everything that this will just a summary of everything that we discussed a while ago. So how do we differentiate your primary polydipsia, Doc, from your central diabetes insipidus, from your nephrogenic insipidus, from water deprivation to your SIDH? Now this is the most important test that we have to request. The serum ADH, the serum osmolarity, the urine osmolarity. Ito yung tatlong to. Ito lang yung tatlo. These 2 here will just I'll just explain how to identify this one. Basta yung tatlong important test is your serum ADH, your serum osmolarity or your serum sodium, and your urine osmolarity. Serum ADH, ADH level. Serum osmolarity, yung asin na tinatawag natin sa katawan. urine osmolarity, gaano karaming asin ang napupunta sa ating ihi. So let's check. Primary polydipsia, we discussed this one. Primary, kumbaga, there is water intake, right? Parang umiinom ka lang ng tubig. So, once you drink water, what happens? Lalong mas marami ka ng water intake. So in short, kailangan mo pa ba ng ADH para mag-conserve ng water? Of course, no. So expected serum ADH will be low. Kasi nga, maraming tubig, nagiging malabnaw ang ating asin sa dugo. Kaya, decrease ang osmolarity kasi maraming tubig. Doc, paano po ang urine osmolarity? Kasi nga, marami kang tubig. So, kung marami kang tubig, pinapalabas natin sa ating katawan kasi hindi natin kailangan ang sobrang tubig. Kaya, yung asin sa ating ihi ay nagiging hypoosmotic. Doc, paano po ang central diabetes insipidus? Remember your central diabetes insipidus? May destruction or deficient ang iyong serum ADH. So, in short, given na yan, your serum ADH will be low. Kasi nga, low ang ating serum ADH. Ano nangyayari sa ating serum osmolarity? Your serum osmolarity will be increased because of excretion of too much water. Kasi nga, nag-i-excrete ka ng maraming tubig, nagiging mataas ang ating serum osmolarity. Anong nangyayari sa ating urine osmolarity? Kasi nga, you are excreting of too much water, nagiging hypoosmotic. Now, let's proceed with nephrogenic diabetes insipidus. Your nephrogenic diabetes insipidus, remember, meron kang antidiuretic hormone, kaya lang hindi nagre-react ang ating katawan. Hindi nagre-respond ang kidney sa antidiuretic hormone. So, anong nangyayari po, Doc? So, in short, your serum ADH will be increased because of increased plasma osmolarity. Kasi nga, hindi nagre-respond sa antidiuretic hormone. Hindi siya nagko-conserve ng water. Pag hindi siya nagko-conserve ng water, it will increase your plasma osmolarity. So, anong effect niya sa serum ADH? Tataas din. Now, sa serum osmolarity po, Doc, anong nangyayari? Increase ang ating serum osmolarity because of excretion of your too much water. Kasi nga, remember, your diabetes insipidus and nephrogenic diabetes insipidus, ang nangyayari is, there is excretion of too much water. So, ano nangyayari sa ating urine osmolarity, Doc? Nagiging hypoosmotic. Paano po ang water deprivation? Explain natin to kanina. Alam niyo na to. Pag water deprived ka, so in short, wala kang tubig. So paano ka makakonserve ng tubig? Tataas ang level na inyong ADH. So in short, your serum osmolarity could be high or normal. So in short, your urine osmolarity will be hyperosmotic. Kasi nga, kailangan mong mag-preserve ng tubig. In short, nagiging mas maraming asin sa ating ihi. Doc, paano po ang SIDH? Your SIDH, there is excess serum ADH. Napakarami, excess, kaya double arrows kasi nga maraming ADH. So ano nangyayari sa serum osmolarity? There will be decreased serum osmolarity because of reabsorption of too much water. Sobrang dami nating antidiuretic hormone. So in short, mas maraming tubig ang pumapasok. Dahil maraming tubig ang pumapasok, nagiging malabnaw ang ating dugo because of reabsorption of too much of water. And then, sa urine, ano nangyayari sa urine? Nagiging hyperosmotic kasi pinapasok natin ang tubig, ang natitira na lamang ay ang asin sa ating ihi. Nagiging hyperosmotic. Doc, ano po yung urine flow rate or water clearance? Remember, pag high ang urine flow rate, there is a positive water clearance. Pag low ang ating urine flow rate, there is a negative water clearance. Ano po bang ibig sabihin? Pag urine flow rate, in short, yung tubig nakakalabas lang ang tubig sa ating ihi. In short, pag hypoosmotic, meaning masyadong maraming tubig, the urine flow rate is high. Urine osmolarity is hypoosmotic. Urine flow rate is high kasi lumalabas lang ang tubig. Paano ang hyperosmotic? Remember, pag hyperosmotic, kinukuha or kinukonserve natin ang tubig sa ating ihi. Ayaw nating palabasin ang tubig, kaya ang urine flow rate is low and your water clearance is also negative. So when it's high, your water clearance is positive. Water clearance, kumbaga, lumalabas lang ang ihi. Lumalabas lang ang ihi. Pag mataas ang urine flow rate, positive ang ating water clearance. I hope that's clear. Now, let's proceed with diabetes, another test for antidiuretic hormone or diabetes insipidus. So we have this test, your water deprivation test, or your endogenous or your exogenous administration of your antidiuretic hormone. So your water deprivation test will just tell us whether the patient has diabetes insipidus, while your endogenous or exogenous administration of your vasopressin will give us if the patient has a neurogenic or nephrogenic DI. In short, water deprivation is the screening. Your endogenous or your exogenous administration of your AVP is the confirmatory whether it is a neurogenic or nephrogenic. So let's proceed first with water deprivation. Parameter, parehas pa rin kanina. ADH level, plasma osmolality, and urine osmolarity. ADH level, sa normal na individual, it should be increased. Pag meron kang diabetes insipidus, baba. Kasi nga, wala kang ADH level. Could be may deficient or resistant ang iyong ADH level. Paano naman, Doc, ang plasma osmolality after water deprivation? Normally, dapat kung magde-deprive ka ng tubig, it should be decreased. Pero if you have diabetes insipidus, it is increased. For urine osmolarity after water deprivation, the normal response should be increased. If patient has diabetes insipidus, there will be a decreased urine osmolarity. Now, if ever we were able to confirm the value of patient with DI with this result, now we will say that the patient has diabetes insipidus. Now, the next step will need the next step after doing water deprivation test is doing your endogenous or your exogenous administration of your vasopressin. So what is the parameter? Plasma osmolality after administration or urine osmolarity after administration. Normal. What is the normal result? Normal to decrease. So in short, ano ba ang nangyayari sa plasma osmolarity mo if nagbibigay ka ng antidiuretic hormone? So dapat, 'di ba, kung nagbibigay ka ng antidiuretic hormone, ano nangyayari sa plasma osmolarity sa normal na tao? It should be normal to decrease. Ano nangyayari sa urine osmolarity after antidiuretic administration? It will be increase. So how are we going to differentiate neurogenic to nephrogenic using your exogenous vasopressin administration? For plasma osmolality after ADH administration, your neurogenic DI will have a normal to decreased response, while your nephrogenic will have an increased response. In your urine osmolarity after ADH administration, there will be an increase in neurogenic, and opposite in your nephrogenic, there will be decrease. So that ends our lecture for today, and I hope that you learned something from today. I know that it's quite overwhelming. There are so many concepts that you need to understand, but as you read and go over with the notes, I hope that you will be able to understand those concepts, because at the end of the day, it's the concept that I want you to really learn. You don't have to memorize everything, just understand the concept, because on my quiz, it's all about the concept. There might be recall question, case series type of question, but basically more of the concept, because I want you to understand this by heart, because it will keep on repeating and repeating, and every concept that you will study here will be used in the different subjects. So I hope that you learned something, you had fun. I know it's very tiring, very overwhelming, but I'm sure you really had fun. And if you have any questions or if you have any doubts, please do not hesitate to ask me those questions. You can PM me anytime. You can PM me through my social medias, but I guess there is a proper forum for that. You can post the questions, and wherein I will answer those questions. As far as I am free and I will be able to answer those questions. If nothing else, I hope that you really had fun. I know it's very tiring. On my part also, kasi na-repeat ko siya twice. And And one thing that I want you to learn is, life lesson naman, I guess one of the important thing that I want you to know is that you have to be kind all the time. You have to be kind to your teachers. You have to be kind to your classmates. You have to be kind to your family. And above all, you have to be kind to yourself. God bless everyone. Good luck and happy aral. Thank you. Bye.